Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article RIBBON-1, randomized, double-blind, placebo-controlled phase 3 trial of chemotherapy with or without bevacizumab for first-line treatment of HER2-negative, locally recurrent or metastatic breast cancer by authors Nicholas J. Robert et al. My name is Lisa Carey, and I am the Medical Director at the University of North Carolina Breast Center. My oncologic specialty is medical oncology. In a randomized phase 3 trial of bevacizumab added to capecitabine in pretreated metastatic breast cancer patients published in the Journal of Clinical Oncology in 2005, Miller and colleagues found an augmented response rate, but the study did not meet its pre-specified primary endpoint of progression-free survival and was considered a negative trial. Then two first-line trials, ECOG 2100 and Avado, using a taxane-based backbone, both demonstrated improved response rate and progression-free survival, but not overall survival, with the addition of bevacizumab to chemotherapy. The current multi-center international phase 3 placebo-controlled trial, known as RIBBON-1, was designed to examine whether this benefit of bevacizumab was specific to the taxanes, or if the benefit could accrue regardless of the chemotherapy backbone. Participating patients were previously untreated for HER2-negative locally advanced or metastatic breast cancer, were otherwise healthy, and in particular had no CNS metastases and had low bleeding risk. They were randomized to dealer's choice chemotherapy, in which the physician could choose among a menu of every third week options, with the primary choice being capecitabine at lower doses than in the prior phase 3 in the pretreated setting, or non-capecitabine options, including non-paclitaxel taxanes, such as nanoparticle albumin-bound paclitaxel or docetaxel, or a variety of anthracycline combination regimens. The investigator needed to choose the chemotherapy regimen first before the 2-to-1 randomization to add either bevacizumab or placebo was performed. The bevacizumab was dosed at 15 milligrams per kilogram every 3 weeks, and reevaluation occurred every 9 weeks. The primary endpoint was investigator-assessed progression-free survival, with secondary endpoints including independent review committee-determined progression-free survival, overall survival, 1-year survival, response rate, response duration, and safety. Upon progression and unblinding, patients could participate in an open-label post-progression phase to receive bevacizumab with a second-line chemotherapy chosen by the treating physician. Of note, for the placebo arm, this represented a crossover. The capecitabine and non-capecitabine cohorts were each 600 patients, with stratified intent-to-treat analyses planned looking for a 25% improvement in progression-free survival from 6 to 8 months in the capecitabine arm, and a 30% improvement from 7 to 10 months in the non-capecitabine arm. 1,237 patients enrolled at 232 sites in 22 countries. The authors do not break down the accrual by sites and regions, which would have been interesting. The median follow-up at the time of reporting was just under 16 months in the capecitabine arm and 19 months in the non-capecitabine arm. The capecitabine arm and non-capecitabine arms differed in predictable ways. The patients chosen to receive capecitabine had shorter disease-free intervals and had had more therapy for their early breast cancer, including surgery, radiation, and adjuvant systemic therapy, including anthracyclines, compared to the taxane anthracycline arm patients. 461 of 1,237 participated in the open-label bevacizumab chemotherapy second-line phase. This represented 49% of the placebo arm and 32% of the bevacizumab arm. Adding bevacizumab to chemotherapy improved progression-free survival, as illustrated in Figure 1 of the manuscript. In the capecitabine arm, progression-free survival increased 31%, from 5.7 to 8.6 months. In the taxane or anthracycline arm, progression-free survival increased 36%, from 8 to 9.2 months. Both were highly statistically significant. Examination by clinically identifiable subsets, shown in Figure 2, did not suggest any group with greater or lesser benefit. Of note, the triple-negative subset had a 28% improvement in progression-free survival with capecitabine and 22% improvement with taxane anthracycline. Neither was statistically significant, but was not notably dissimilar to other clinical subsets. Whether taxane or anthracycline-based chemotherapy was used also did not seem to matter. Independent review had similar results. In addition to improved progression-free survival, response rate was significantly improved from 24% to 35% added to capecitabine, from 38% to 51% with taxane or anthracycline. There was, however, no statistically significant improvement in overall or one-year survival. Toxicity was predictable, including hypertension in about 10% and proteinuria in about 2 to 4% with bevacizumab, and the expected chemotherapy side effects depending on the choice of drug. There were 6 gastrointestinal perforations and 15 bleeding events. Most occurred in the taxane bevacizumab cohort. Treatment discontinuation due to adverse events was the same in the bevacizumab and the placebo arms in the capecitabine cohort, but was higher with bevacizumab compared with placebo in the taxane anthracycline cohort. Specifically, this was 24% versus 8% with the taxane and 14 versus 4% with anthracyclines. This suggests that bevacizumab may be easier to combine with some drugs than others. Compared with the earlier randomized phase 3 trial of bevacizumab added to capecitabine, which failed to meet its primary endpoint of progression-free survival improvement, this one did, specifically for bevacizumab added to capecitabine. Possibly this was due to the earlier line of therapy. Like the other randomized bevacizumab trials in this disease setting, the addition of bevacizumab did not appear to alter overall survival. However, this particular report is immature for that endpoint, and this study, like Avado, allowed crossover that would confound the overall survival endpoint. A subsequent pooled analysis of ECOG 2100, Avado, and RIBBON-1 at ASCO 2010 by O'Shaughnessy and colleagues revealed no evidence of an overall survival advantage to adding bevacizumab to first-line chemotherapy. At the time of the initial reporting of this study, the results could be used to say that if you were going to use bevacizumab to improve response or progression-free survival in the first-line setting, it probably did not matter which chemotherapy you used. The subsequent positive report of RIBBON-2, which allowed a similar but more expansive menu of chemotherapy options in the second-line setting, with a randomization to bevacizumab or not, bolstered the impression that the chemotherapy choice is not terribly relevant in choosing whether to use bevacizumab. There is currently no known selection strategy to identify patients with metastatic breast cancer most likely to benefit from bevacizumab. This landscape will certainly be altered by the FDA's decision in late December 2010 to remove breast cancer from the bevacizumab label, because the committee felt that without an overall survival advantage, there was not enough benefit to bevacizumab to outweigh its risk in this disease setting. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.